Am I audible?
Yes.
Am I audible? Good evening, everybody. In continuation of yesterday's webinar on history of pandemics and its multifaceted impact on the global world, I welcome all of you on behalf of the Department of History and the Department of Political Science, Prafulla Chandra College. From endemics to pandemics, history will register COVID-19. Today, we also have a panel of distinguished speakers whose deliberations will reveal how people, societies, and regimes have perceived and reacted to those pandemic outbreaks. This webinar hopes to provide a broad historical insight into COVID-19, showing how epidemics and pandemics need to be studied within their broader social, cultural, political, scientific, and geographical context. I welcome you to this webinar once again. And now I hand over the microphone to Piali Sheth, the Joint Convener, to conduct the session. Piali, please.
Thank you, ma'am. Good afternoon again to everyone. I, Piali Sheth from the Department of Political Science, Prafulla Chandra College, and also the joint convener of this webinar, take this very opportunity to thank all our distinguished speakers from yesterday for such an enriching and intriguing talk. And also to all our listeners, a big thank you. As I begin with the very first technical session of day 2, I would like to convey to all our listeners that you may please kindly post your questions and comments in the comment section of your YouTube link, as our very first distinguished speaker would like to address your questions immediately after the talk. This gives me the privilege to introduce to all of you our very first distinguished speaker of today, Professor Dr. Sujata Mukherjee. Professor Dr. Sujata Mukherjee is currently professor at the Department of History and is the former Dean of Arts Faculty and also former Director, Center for Gandhian Studies, Rabindra Bharati University, Kolkata. She was ICCR Chair for Modern Indian Studies at Victoria University, Wellington, New Zealand. She also received postdoctoral research grant in History of Medicine from the Wellcome Trust of London, the United Kingdom. She visited and remained associated to the Rockefeller Archives Center, New York, USA, as Rockefeller Fellow in 2018. Professor Mukherjee served as visiting fellow and visiting professor in different institutions, including the Jawaharlal Nehru University in the Zakir Hussain Center for Educational Studies in New Delhi, the Indian Institute of Science, Bengaluru, Center for Contemporary Studies, Vishwabharati Shantiniketan, Northeastern Hill University in Shillong. Among other subjects, she teaches gender history, women's history, history of ideas, history of science, technology, medicine, and environment. I welcome you, ma'am, to our webinar, and I would kindly request you to please deliver your talk.
Thank you. Good afternoon, everyone. I would first like to thank the organizers of this webinar, especially the Honorable Principal, Prafulla Chandra College, members of Internal Quality Assurance Cell, Department of History and Political Science of Prafulla Chandra College, and especially Dr. K.K. Dr. Roy, Dr. Piali Sheth, for inviting me. Now, as we all know, COVID-19 has transformed life around the world. And it is very pertinent that in this context, this topic has been chosen for this webinar. However, it needs to be remembered, as Honorable Principal had pointed out yesterday, that this is, of course, not the first time that mankind is facing such pandemic and such challenges. Both pre-modern and modern world had witnessed outbreak of pandemics on a large scale with various ramifications. As it is well known, history repeats itself, and so we should not forget the past. We should look back and try to find out whether we can learn from our past lessons anything which would help us handle the crisis nowadays. There are, of course, continuities as well as changes. Now, yesterday, as many pictures of Spanish flu were shown by Dr. K.K. Dr. Roy, and we know that 100 years ago, the same kind of defensive measures were adopted, like wearing masks, keeping safe distance, social distancing in today's parlance, quarantines, as well as closing of schools, colleges, theaters, public auditoriums, rules forbidding spitting in the public places, which we are seeing nowadays as well as defensive measures to fight with COVID-19. In India, also, apart from the Disaster Management Act, many states have invoked provisions of Epidemic Diseases Act of 1897, which is a colonial piece of legislation which was passed in 1897 by the colonial government in India to control plague epidemics. Today, I would even look back further to the 19th century, and we'll discuss about cholera pandemic which shook 19th century world. And my specific focus would be, of course, colonial Bengal, which happens to be my area of research and investigation. 1817, that is recorded in history as the year when this virulent cholera pandemic first was noticed and reported to have broken out in Jessore, in the town of Jessore, district of Jessore, now in Bangladesh. From there, it spread to Calcutta and other parts of Bengal. Very rapidly, it also spread to the northern and western parts of India. Between 1817 and 1823, there was this first wave of cholera pandemic. This first wave had an Asiatic expanse. It hit China through the western port of Canton in 1820. Later, between 1822 and 1824, it sprawled through the Yangtze. It also attacked Korea, and it is recorded that from 10,000, it attacked from 10,000 to 1 lakh people who perished in 1821. It also entered Japan around 1822. It struck Sri Lanka in 1818 and Philippines, Borneo. Through land routes again, it went to Western Afghanistan, Syria, Russia, even Africa, east coast of Africa. Egypt was hit hard around 1823. So this was the second wave. Altogether, throughout the 19th century, there were 6 waves of this cholera pandemic, hitting different parts of the world in different times for shorter and longer duration. For example, in the later part of 1820s, new countries were invaded like Poland, Hungary, Germany, Finland, Sweden, Vienna, France, England, Scotland, Wales, around 1831. So this now traveled from Asia to European countries. In the second wave, USA, it entered USA even, lasted from 1832 onwards until 1849. It is recorded that there it killed almost 150,000 people. And then again in the next decade came another wave which lasted for a long period, then fourth, fifth, sixth. The last wave came around 1899 and it continued till 1923. Now, of course, how did it spread? That is the question, which seems very intriguing, because perhaps we might tend to think that today the world is connected, but long, long ago, 200 years ago. Was it still connected? Yes, of course. There was maritime connection, and also there were connection made through troop movements. You know, uh, trade routes, to maritime activities, people traveling for pilgrimage and other reasons, troop movements, warfare, to all this cholera pandemic spread all around the world. Many European nations then devised or imposed, it was not devised during that time, quarantine measures were there in the past also, in the 15th, 16th century. Now again, this, many of these European nations, they imposed quarantines on migrant people and pilgrims even. So this was one important fallout, and there are other different important fallouts. For example, there was international cooperation for combating this disease. There are a series of international sanitary conferences starting from 1851, and it continued till 1938. There are 14 such international sanitary conferences held in different parts of the world. These were actually precursors of the World Health Organization of today. The first one was held in Paris in 1851. There, the sanitary authorities of as many as 14 European nations met. The second one was held in 1859 in Paris. Now, the third one was a watershed in the history of cholera pandemic, because there it was pointed out very emphatically that pilgrims who came to Mecca for Hajj, that was an annual thing, from the Indian subcontinent, they were the vectors of spread of cholera pandemic to Red Sea region and from there to Europe. Um, and also, India's inland pilgrimages were also blamed. The pilgrims were within India who went to attend different pilgrimage sites and religious fairs. They were blamed for spreading cholera, for transmitting cholera. Now, here one interesting thing is that there was always a division of opinion within the medical communities about how cholera was spread. Because at that point of time, there was no germ theory of disease. Germ theory of disease actually started to come to the foreground from the 1880s onwards. Still, there was a kind of idea that there was some kind of contagion which was spreading cholera. Human to human transmission was happening. So there were contagionists who said that due to human to human transmission, this cholera was spreading. There were others who were non-contagionists. They blamed the environmental factors and bad sanitation, poor sanitation, for dissemination of cholera. So medical communities were divided about the causes of cholera. And accordingly, the measures prescribed by these two kind of people also varied. Now, you see, as I was saying, the contagionists, they wanted to impose quarantines on pilgrims, and it was adopted in 1861. From 1882, we more and more we see that European nations were taking stringent measures, and the British Indian government then were told to provide the ships which were carrying the pilgrims to towards Makkah, to provide those ships with clean bills of health, which would say that no passenger of those ships were infected, or they have totally great health. But even then, after these pilgrims, they disembarked in the pilgrimage places, they were put into quarantine. Then they were allowed to go to Mecca. So This quarantines was imposed very strictly with internationally. England was, of course, not very much for adopting this kind of quarantine because the maritime lobby was very strong there, and ultimately cholera was combated in England in the later half of the 19th century through good sanitation measures, through spread of hygienic habits, and those kind of public health measures. On the other hand, another interesting thing we find out is that many medical men were saying that not these pilgrimages or pilgrims were acting as transmitter of cholera. Actually, they were not the vectors of the disease, they were the victims of the disease. It was basically the bad sanitation in the places of pilgrimages, that those were unhygienic conditions of those places of pilgrimage, those were to be blamed for spread of cholera. Even the British Medical Journal, the BMJ, also published many articles where the medical authorities spoke about this, but their views were ignored, they were set aside, and the European nations and sanitary authorities internationally, they did not adopt this kind of view, they did not support this view, they put on quarantine measures. And another interesting thing is that when cholera traveled outside India, in Europe especially, in England and other places, it was termed as Indian cholera or Asiatic cholera, because India, Bengal, and other places were then thought to be the hotbed of epidemic of cholera and other epidemics. So there we see what can be called Asianization of cholera, that it was basically Asian disease. Now the Indians at that point of time, they responded to this, like famous Dr. Mohanlal Sarkar and his many fellow uh, researchers, they pointed out that no, Bengal was not an endemic region, and cholera actually spread in Bengal and other parts of India through European troop movements. Because during that time, I mean, from the late 19th, late 18th century, early 19th century also, the British were fighting wars in different parts of India, the British colony, East India Company fighting wars. So there was a lot of troop movements. And in fact, there is record that around 1814, there is also outbreak of cholera in the Fort William among the army camps. So this view was not entirely tenable. And later on also in the 1960s, there had been many kind of researchers, and these researchers tried to put forward the theory that the cholera which was caused uh, uh, in Europe and in India, they were caused by different strains of bacteria. So it was not the same strain of bacteria which caused cholera in India, they were causing in Europe. So in this way, there have been criticism, lot of criticism about this theory of Asian cholera or Bengal being the homeland of cholera. But this continued to persist. Once these prejudices and perceptions grow, it takes a long time to discard those. They continue. Nowadays, also, during the COVID-19, we are seeing that although it is caused by a virus, basically, sometimes there are some ethnic groups are being blamed, and their dietary habits, their cultural habits are really blamed for spreading the disease and all that. Now, uh, about Bengal and India, we see that the sanitary habits of the Indians were blamed as the root cause of cholera by many medical authorities, British medical authorities in India and Bengal. About Bengalis, we see in many colonial official reports that it was pointed out that Bengalis have little regard for sanitary rules in public spaces, especially in bazaars areas, in streets. They really don't care about conservancy and keeping those streets clean and bazaars clean. The colonial government actually put the onus on the Indians for the recurring epidemics of cholera. Throughout the 19th century, of course, the sanitary conditions in different parts of India, particularly the villages, remained very, very poor. Colonial government would blame people for lack of awareness. They would point out, they would write that people in India, Bengalis, they have primitive idea of sanitation. They also said, and this is very, very interesting, I quote, customs of the East are very unhygienic and insanitary. So you see, this was more than just a kind of medical statement. This was also kind of racist and culturally biased statement that customs of the East were blamed as being very unhygienic, very filthy, and very dirty. So this basically had a kind of political motive also, because in this way the imperialists were trying to formulate a theory or an ideology of governance. They were actually basically trying to establish the cultural superiority of the West, and they would claim that Western civilization, Western culture had better standard of hygiene than Oriental civilization, Oriental culture. So Indians need to learn from them. Indians need to be under control so that they can remain under the guardianship of the superior Western culture. And rural poor, urban slum dwellers, they were blamed for dirty habits. And what about the middle class and educated Indians? Here also we see that in the view of the colonizers, these people were also to be blamed, but they did not take the responsibility of making people sanitarily aware. It was expected that being the elite and the educated class, they would try to spread sanitary awareness among lesser educated people. In rural areas, the jamindars were expected to take that role, and they were blamed for remaining aloof. And in urban areas like Calcutta, the Calcuttans, the Bhadralok Samaj, they were blamed for not providing leadership. Now, what about the responses of the Bengalis? Did they uncritically accept this kind of views? No. There also we come across several writings where they refuted and they challenged this idea that Bengali people in general had a habitual disregard for sanitation. Some would even argue that, well, in the countryside, even the middle class or the upper middle class people were not economically in a good position. They were facing uh, declining income, and the general people are facing starvation due to price rise. That is why they could not really take good sanitary measures. Not only that, here also interestingly we find a caste dimension was added also. This is very interesting for those who of us who do social history of medicine, that how there are different social dimensions were added to a kind of medical phenomenon. It was said that the higher caste people were in a better place. I mean, they had hygienically cleaner habits than the lower caste people. The higher caste Hindus were said to be clean in their habits than lower caste people. Thus, Bhadralok, Bengali Bhadralok could sometimes internalize the criticism of the rural folk made by the colonizers. And they would also blame the poor villagers for not having notion of conservancy. Of course, there were multiple kinds of views. There were other people also who would say that the poor villagers also faced economic stagnation and economic decline. So could not really adopt good sanitary measures. Again, by the imperialists, by the colonizers, Indians and Bengali pilgrims were seen as sources of disseminating cholera. Uh, Now, here we see about imposing any kind of quarantine measures on the pilgrimage, we find out that for combating cholera among the troops, among the army, because many army people died from cholera in the early 19th century. And the British government, or East India Company's government, and later the Queen's government, they always prioritized the health needs of the armies. So they were very serious about protecting the health of the army. In fact, historians have said that it was cholera and other epidemics which shaped imperial public health policies. And in case of cholera, to combat cholera, we see that quarantines were imposed from time to time on army barracks. The army people were not allowed to go into the nearby villages or bazaars, mingle with local people, because those were seen as sources of cholera epidemic. So quarantine measures were adopted in the army barracks from time to time, partially and temporarily. And also, more importantly, good sanitary measures were adopted. A great deal of money, imperial money, was spent for providing good sanitary measures in the army barracks and army cantonments. And the colonizers were not at all any miserly in this, but they never took the financial responsibility of providing good sanitation to the local people, to the villages. And also in the cities, we see that municipalities and in the villages, the district boards were uh, actually formed from the 1870s and 1880s, who were to raise their own revenue by imposing taxes on the people. And from that money, they were supposed to maintain good drinking water, supply of good drinking water, provide good sanitary facilities to the villages and to the city people. And sometimes funds were provided, but those were very paltry sums. I mean, those are never enough for providing all sorts of good sanitation facilities in the villages and in the towns also. So there was fund crunch also always. And it was impossible to tax the poor villagers to get that amount of money which was needed for providing good sanitation, good safe drinking water, and everything. And the imperial government would pass the blame, they would not pass the blame on the Indians, on their habits. They would critique their habits only. Thus, they would pass on the blame to the Indians themselves. Whereas they were spending lots and lots of money to keep army in good health. Now, another reason why not much much measures were adopted, curative or preventive, was because, as I was pointing out, the medical communities were divided about causes of cholera. Within the British medical communities in India, also there were two opinions. There are the contagionists, non-contagionists. People like J.M. Cunningham, who became the sanitary commissioner from 1868, he was very powerful, very influential. So was J.L. Brighton. And this duo, we see, they exercised a lot of influence on imperial government, because they always believed in the environmental paradigm of the disease. They would blame the local conditions, environmental conditions, for causing cholera. They were opposed to the pilgrim theory. But sometimes during pilgrimage, Kumbh Mela in Haridwar, in Allahabad, in 1880s, 1890s, severe epidemic of cholera broke out. Now, one section would say that it was due to the pilgrims who were not obeying the good sanitary rules. They were spreading the cholera. But now imperial government then was very shaky. They would not adopt any strong
আচ্ছা
measures.
ক্যামেরাটা কোথায়
ক্যামেরাটা হলো এই যে এখানে এইখানে
ক্যামেরা
Is it okay? Shall I carry on? Is it okay? Okay. So you see, they thought that after the rebellion of 1857, according to Queen's proclamation, we know that it was undertaken that the imperial government would not take any measure to insulted religious sensibilities of the people. So they could not really stop pilgrimage or could not do those sort of works. Sometimes good sanitary measures were taken, but those were inadequate. Those were not adequate sanitary measures. And in Bengal, we see also this, there were two kinds of opinions. One group of officials would say impose strict quarantines on the pilgrims, impose pilgrim tax even, so that from that tax, the money would be spent for providing good sanitation in religious fairs, in pilgrimage sites and everything. But the local people, the Jamindars and others, and also educated Indians, they were opposed to pilgrim tax. They said the imperial government should take the responsibility of incurring the cost of providing good sanitary measures. So ultimately, only ad hoc piecemeal measures were taken. Not much preventive measures were taken. The colonial government was not ready to take up responsibility of providing costly sanitary measures for general population. Um, what about the curative medicine? Was there any cure in the hospitals or facilities provided for treatment of cholera? Now, you see, at that point of time, there was no outright cure for cholera. Okay. Uh, so sometimes there were cholera pills. That was a kind of an empirical medicine. Like those were a kind of amalgamation of Indian ingredients and Western ingredients. They would put in black pepper, calomel, opium even, to make those cholera pills. And those cholera pills were sometimes distributed to police stations, to post offices, to general people when cholera came. Sometimes they were effective, and most of the time they were not so effective. Now here what we see is that there are a lot of in practitioners of indigenous medicine when the British came to India, the Kaviraj, the Hakims, and other sorts of medical men, therapeutic practitioners. Initially, the Western institutional medical care actually adopted this indigenous medical practitioners of indigenous medicine within the system of healthcare. But as 19th century progressed, the state marginalized the indigenous medicine. Yet that did not mean that these practitioners of indigenous medicine died. Far from it. They practiced at the grassroots levels. Traditional practices continued. In fact, they actually provided medical care to majority of the people. So you see, the colonial medicine actually meant that there was production of knowledge in a colonial setting, both by the practitioners of Western medicine, practitioners of homeopathy, practitioners of Kaviraji, Ayurveda, and other sorts of medicine. Of course, Professor Deepak Kumar correctly points out that although such production of knowledge created a syncretic environment, there was domination and marginalization which lurked in the background. However, there was pluralistic healthcare provided to the people. Now, in the institutional care, we see that there were a number of hospitals. Of course, the numbers were very few in Calcutta and other towns and mafahsils, and there were dispensaries. There was hospital care, there was dispensary care. And what about the cholera patients? Did they go to these places for getting treatment? Now, here we see that the colonial officials would say that not many cholera patients were coming for receiving treatment. Why so? Because, first of all, there was kind of racist discrimination. In certain hospitals, the European wards were better provided with better nursing facilities, cleanliness, and the native wards were neglected. And there was also caste taboo among the wealthier Indians, high caste people. So they would prefer home care. They would not easily go to the take care in the get treatment in the hospitals. In the rural areas, we see that in many places the pilgrims who are going to Puri and other places, sometimes they would get cholera, attacked by cholera, migrants and laboring population. they would pick up by the police from the streets and they would be admitted in the hospitals. They would die most of the time in a hospital area or in the dispensaries, and the people would get very scared. They would say that these places are haunted, there are ghosts. So there was this kind of mentality, very fear and panic. Because cholera itself was very much instrumental for creating panic among the people. Because cholera was such a disease at that time that it struck so rapidly, and one person is healthy at this moment, the other moment he's totally dying. And that was a horrifying sight. People were panicked also, and there are stories also. So neither in the dispensaries nor in the medical facilities in the urban areas, we see that bed numbers were very poor, and also people would not really like to go there. So the wealthier peoples, they would prefer to appoint physicians. There were homeopaths, there were allopaths, there were kabiraj, there were hakims. Sometimes it also happened, we know from the records, that the wealthier people would appoint more than one practitioners at the same time if they could afford the fees. That was a status symbol also. Mohanlal Sarkar is a famous, he was also qualified allopath, but then he switched over to homeopath practice. He had a roaring homeopath practice, and there were others as well. So there's all sorts of pluralistic medical care, uh, but where kind of taken um, uh, recourse to by the people who could afford this. But the general population, rural population, they had to depend on cholera pills, which were not exactly doing much good. That is why year after year, decade after decade, we see that the villages and urban slum dwellers in Calcutta and other areas, they died in large number. Cholera remained a disease of the poor during the colonial time. And hospitals had limited space, dispensaries were limited space, not very effective cure was available, sanitary measures were also lacking. So that is why there was high rate of death from cholera among the poor people in Bengal and other areas of India. So this was the picture of healthcare and the cholera pandemic, which created a lot of panic, lot of mortality, sickness among the people throughout the 19th century. On the other hand, I would like to briefly say a few things about women's health also, because I don't see anyone. Of course, Rajeshi Chakraborty spoke yesterday about the present context, uh, prostitutes and others. And during cholera pandemic also, I would like to point out, I have seen in the writings, vernacular Bengali writings, the Bhadralas complained about unsuitable conditions in the hospitals and dispensaries for treating women. There was social taboo, there was caste taboo, and in general ward, cholera patients were kept. So people were complaining that no Bhadra Mohila would go to seek hospital care during cholera times. From late 19th century, we see that many writings were there coming out about high rate of maternal death. Colonial government neglected women's health care. Whatever little they did, of course, primarily for the army and also for the general people a little bit, but they did not take at all the responsibility of providing good hospital care for the women. And we see that private agencies like the missionaries, like doctors, lady doctors who were coming to India from abroad, they tried to provide clinical health care to Indian women. But Indian women actually suffer from very poor health status, very poor nutritional status. And I would like to say here that during Spanish flu, it is recorded in official reports that Indian women died in disproportionately high number. This was against the world trend. So Indian women died in greater number during Spanish flu, and later on also in other epidemics where you get statistics also. So Indian women were suffering from poor nutritional standard, bad diet, malnutrition, poor maternal health was showing all these things. And that is why the women suffered a lot more. They were marginalized among the marginal people. They were more vulnerable. I mean, they belong to the most vulnerable section of the Indian population throughout the colonial time, in from the perspective of healthcare and other perspectives. This is very important because, in today's context also, we are seeing that COVID-19 is creating a great deal of problems for women. That is why sometimes it is also advocated that a women-centric approach is needed for combating COVID-19, because all over the world, uh, women constitute no less than 70% of service staff. So we have to fight this gender discrimination. There is a lot of rise in domestic violence and other issues also. So we need to take care of women. We need to take care of women-centric approach. That is a very powerful view. And let us also hope when this crisis goes away, we'll live in a better world to fighting and taking measures against all sorts of discrimination, including those based on gender. So I stop. I end my discussion here, my talk here. Thank you very much for bearing with me.
Thank you so much, ma'am. It was really interesting to listen to you, and I'm very sure it was also very enriching for all our listeners. Now, may I call upon Professor Suparna Ganguly from the Department of Economics, Prafulla Chandra College, to please conduct the interactive session for Professor Shujata Mukherjee.
Thank you, Piali.
Yes.
Thank you, ma'am, for this excellent deliberation. Now we have got quite a number of questions we've collected. So should I present them together and you'll respond to them?
No, I think
Or
one by one would be.
one by one?
If
Okay.
just a minute, if there are
Yes.
similar type of questions can be clubbed together.
Okay, ma'am. Okay,
Okay.
sure. Okay. So we start with Debodhuti Banerjee's question. He's asking, you mentioned that Japan too was affected by cholera in 1820s, and we know that Japan, till its opening by the Permission, had been a closed nation. Then how would they get contacted with such disease, if you could elaborate?
Yes, there are a plenty of articles on that because of trade and certain amount of, because there were some kind of trade going on. So through trade, basically, this attack happened. I mean, it was not in large scale. It was not open to the West, because there were certain kind of Asian trade also going on. So through that route also they traveled.
Okay, thank you, ma'am. Now, Jagannath Dalal asks, can we call the pandemic of 1817 as the Asian cholera or Indian cholera?
So that's what I was telling. I was trying to say that this was a kind of Asianization happening. One group of people would say that it was Asian cholera, but that was refuted and challenged. I think that it is not entirely, I mean, at that point of time, it was called Asiatic cholera, true. But later researchers, I think it would be more logical if we don't name it Asiatic cholera, because the cholera which was happening there in Britain and other, not necessarily the same kind of symptoms were there. So in the light of later researches, it should not be called Asiatic cholera. But at that time and later on also, this bias and this prejudice continued. Like, would you like to call it coronavirus Chinese virus? That is my question.
Right, right. So the next one is from Shravani Shen. She wants to know, seeks your opinion on what was the reason for the cholera bacteria to turn into a virulent variety to cause pandemic?
Actually, I think this is a kind of my question which I also want to ask to the microbiologists. You know, this is a very specifically a question which should be answered properly by a microbiologist. Because at that point of time, I was speaking about the particular takes historically about cholera, how it was. I mean, what were the theories? Those were in place, and how it was seen. What are the ramifications about that? Now, this specifically, why? What was the reason cholera bacteria turned into virulence? Maybe that was because of the local factors in some places. Local factors were very much in place, and also because of the environmental factor should have been the people immunity. All these things are um, very much in there. Like it was such a long period of like even nowadays there is uh, so much of work going on about the characteristic of coronavirus, how it mutates. And we are finding that all these for 6 months there are new theories are coming up. But at that time there was no laboratory, where this bacteria could be really studied. So how can you tell without the laboratory, okay, and without that kind of investigation? How could you tell? You can make conjectures, but that would be risky also. There is no laboratory, there is no that kind of facilities, laboratories, and as I said, the germs theories, they came later. They were not even aware that it was caused by a bacteria until Robert Koch. Of course, John Snow was there, who was saying in the 1848-49 that it was a waterborne disease. But the specific bacteria was actually discovered much later. Robert Koch here and other people in other places. So it cannot be known as such. Okay. If you want to know better things, you have to go into deliberations of Robert Koch, really.
Thank you so much, ma'am. The last one is from Rajesh Dash. He wants to know what was the socioeconomic condition of rural Bengal during the epidemic?
Socio-economic conditions of rural Bengal. I mean, that is a very broad question. What I was trying to highlight here in connection with this cholera epidemic and this dissemination, that we get to know the picture that the socioeconomic condition in most of the villages were very, 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 very poor in Bengal. Because there is this, anyone who knows about a bit about the history of Indian economy. There are plenty of books. If you go through N.K. Sinha's book, you go through Amalesh Tripathi's book, you go to other economic historians' books like Tapan Ray Chaudhuri and Economic History of India, Economic History of Bengal, Binay Bhushan Chaudhuri. I think you will know better about the social and economic conditions. That is a very broad theme which cannot be covered here. But for specifically for what I talked today about cholera, of course, the people who are poor, poverty stricken, so they could not really afford to pay the taxes which were imposed by the district boards. And there were many hierarchies also within people. There were the higher earning people, there are the lower earning people. So it was a divided society also. But the economy was land based. There was deindustrialization, very little pockets of industries. So obviously, in the absence of good industries, there are a lot of unemployment, and in rural society there was low income also. Low income. It was characterized by low income, low productivity, and also a lot of diseases. Okay, environmental decline, agricultural decline. It was a picture of decline in the 19th century, of course.
Okay, thank you, ma'am. Uh, I don't see any further questions at the moment, so I hand this over to Piali Seth again for conducting the
Okay,
rest of the session.
is there a question? What you
What
think,
is it? Stravoni?
Shabani Ghosh?
What?
It is showing here.
It is, yes, ma'am. Oh, right. I see this. What do you think plague, cholera, and other pandemic was not, it's not very well constructed.
Not
Uh,
man-made.
Ma'am,
I can read it.
okay, ma'am. So could you just please
It is, yeah,
elaborate on this?
it is asked, what you think plague, cholera, other pandemic was not man-made, but as far as corona is concerned, it's man-made. Is it new way of war? Now man became as weapon. Now,
That's
is it
right.
really, are you sure that it is a man-made? I mean about corona. Are you so sure? I'm not so sure. First of all, your premise that it is man-made. There is a theory, um, and counter theory also. So there are all sorts of theories. The corona man-made, but I'm not sure which one to believe and which one not to believe. And another thing which you asked is about cholera and all that, man-made or not. Mm, I would say that during that time, of course, at least its expansion uh, could be mitigated if there were good measures taken. So in that way, even if it was caused by some bacteria, I think it could be controlled if there were better measures in place. So the dissemination, maybe we cannot really control the breakout of a disease, epidemic or endemic, but we can, I think, control it if we have good intention. Okay, like in malaria during British rule, the malaria, and there is a lot of writings on the field service and carried on the railway expansion, railway embankment, all these caused cholera. So there was human interference which caused, I'm sorry, malaria. So human interference, of course, escalated the disease cholera. So it could be avoided if there are good intentions among the people, among the administrators. Thank you very much. I think that's all.
Thank you, ma'am. Over to
Thank
you, Piali.
Thank you, Professor Ganguly, for conducting this interactive session for Professor Shujata Mukherjee, and thank you, ma'am, for sharing your thoughts. This brings me to our next distinguished speaker, Dr. Lillian Campos. It gives me pleasure to introduce to you Dr. Lillian Campos, who carried out her undergraduate studies at St. Leo University in St. Leo, Florida, and graduated in 2003 with a degree in biology. So, as we were talking about of a microbiologist, here we have in the gracious presence of Dr. Lillian Campos. She received her PhD in 2017 in molecular and cellular biology at the University of South Florida, where she used S. cerevisiae as a model to study genomic instability. In 2017, Lillian joined the Diwal lab at Vanderbilt as a postdoctoral fellow and currently is studying DNA replication termination in vertebrates. I welcome you, ma'am, to our webinar, and I would request you to kindly deliver your talk.
Hi, it's my pleasure to be here. Let me see if I can share my screen. Let's see. Let's see. Give me a second. It's not allowing me to make any changes right now. I'm gonna.
Yes, ma'am.
Okay.
Yes, ma'am. We can see this.
Yes, I'm trying to put this into presentation mode. Okay, it may not allow for me to do that. So I'm going to. Sorry. Okay. I think this is probably. Here we go. Okay. I think it should work now. There we go. My apologies. Okay, so thank you so much for your invitation. It's an honor and pleasure to speak to you guys about a brief history of pandemics and the current challenges that we face with SARS-CoV-2. And so I'm just going to begin with a brief outline of what I'm going to talk about today. So I'm going to talk about the basics of pathogens, so the types of pathogens that we encounter. And then I'm specifically going to talk about the transmission and infection of viruses, how we combat viral pathogens, and then I'm going to discuss some of the major pandemics, which you've already heard today a little bit about cholera, but I will also speak about that. And then I'm going to conclude with discussing modern SARS pandemics and some of the current challenges that we face. So just to put things into context, for humans in relation to microbes, there are approximately 1 to 10 to the 31 viruses on the Earth. And if you laid them end to end, they would stretch for over 100 million light years. And there are 100 million times as many bacteria in the oceans as there are stars in the known universe. So there are many more of these microbes than there are of us. And it's certainly something that we should take notice of and study. So some of the basic pathogens that we encounter are bacteria, viruses, and then eukaryotic pathogens. So as an example, plague is called by Yersinia pestis, which is bacteria. Mycobacterium tuberculosis causes tuberculosis. Influenza is caused by a virus, as is smallpox. And then malaria is caused by Plasmodium falciparum. And fungus can also cause disease, such as Candida albicans, which causes candidiasis. And so I'm just going to discuss a little bit about the transmission of viruses to humans. And so we discussed something called zoonosis, which is how a disease is transmissible from other vertebrates to humans. And this can happen in a number of different ways. One could be through a biting arthropod vector, as is with the mosquito for dengue. You can have a vertebrate reservoir, which is basically just a reservoir is just the source of a viral infection. And so in the case of rabies, an infected bat or dog could bite a human and then infect the human with rabies. Or in the case of something like West Nile virus, you can have the virus be transmitted between mosquitoes and birds, and then a human will be bit by the mosquito and contract West Nile virus. So transmission can also occur from human to human through body fluids, which is the case with HIV or human immunodeficiency virus, aerosol, which is the case for influenza and for measles, and then also the fecal-oral route, which is how polio is transmitted between humans. So I'm just going to give you a very basic overview of how, once you come into contact with a virus, how it actually infects human cells. And so this is just very basic. This is not exactly the only way that viruses infect, but basically the main way that a viral infection occurs. And so you can see here, the virus has these surface proteins that come into contact with receptors on the surface of a human cell, which allows for it to be either engulfed into the cell or for the surface of the viral, for the virus to fuse with the plasma membrane of the human cell, with the purpose of releasing its genetic information into the cell and then hijacking the cellular machinery to use this genetic code to produce viral components, which are then assembled and reassemble the virus to be released out of the cell to infect other cells. And so on the left here, I have an electron micrograph of SARS virus, which you can see all of them along the edge of the surface of this cell. And then I also have an electron micrograph here of SARS-CoV-2. And so there are a number of interventions that have been developed and used to combat viral infections. The first one being vaccines, which basically teaches our immune system to recognize and combat these viral infections. And so I have on the picture on the right, a photo of Sabin and Salk, who developed the polio vaccine. And then as well underneath, a picture of the smallpox vaccine. And then on the bottom corner here, you can see what it looks like after you've been inoculated with smallpox. You actually develop a smallpox, but you don't actually develop the whole disease. And then we also have behavioral interventions, so things that were discussed earlier, such as sanitation, quarantine, and distancing. So in the case of the Spanish flu, on the right here, you can see people are wearing masks to prevent the spread of aerosol. And then when polio epidemic was occurring, people weren't sure how it was transmitted, and they had this thought that they were actually transmitted at pools, public pools, and so they actually closed them in order to try and help stop the spread of polio. And then finally, there are drug interventions. And so I'm not going to go into depth of the diagram on the right, but just to give you an idea, this is just a diagram of viral infection and then all the different targets for antiviral drugs that target different parts of the process of viral infection to stop the infection. And then on the right, there are a number of compounds that have been used or tested to fight HIV. And specifically, these drugs target the reverse transcriptase activity of the virus, which occurs in a couple of different spots here. And so historically, there have been many major pandemics. One of the earliest ones was written about in the history of the Peloponnesian War, written in the 5th century BC. In that case, there was a plague that devastated Athens during the second year of the Peloponnesian War. And Athens at that point was on the cusp of victory against Sparta. And this plague basically, made it so that Athens was defeated, and this ended the golden age of Pericles and Athenian predominance in the ancient world. And so I'm sure as history majors, you've probably discussed how disease has influenced the course of history. But today I'm going to talk about plague, smallpox, cholera, and Spanish flu. And I actually just want to mention, before I forget, they don't actually know what caused this plague in Athens. That's still something that is under debate. And so just to kind of put things into scope, I have a chart here that shows different human diseases based on how contagious it is, so the x-axis here, versus how deadly it is, which is here on the y-axis. And if you notice, most of the diseases are here on the bottom left. And that's because for disease to be successful and to propagate and spread its genetic information, it needs to be somewhat contagious, but not extremely deadly. Because if it is very contagious and very deadly, it will quickly spread, but then quickly die off. So I'm going to talk about bubonic plague, which you can see here if it is untreated, is extremely deadly and contagious, but if it's treated, it remains contagious, but not as deadly. Cholera, which is extremely contagious and quite deadly. And then the Spanish flu, which is contagious, but not as deadly as something as smallpox, which is on the cusp of being contagious and very contagious. Okay, so to begin with plague, it's caused by the bacteria Yersinia pestis, and once it infects the human, it will travel to the lymph node, and it will become inflamed, causing this bubo, which is where bubonic plague gets its name. It can also travel systemically and cause systemic plague, causing gangrene. It can also infect the lungs, causing pneumonic plague. And so there have been 3 major plague pandemics. One that first occurred from the 6th to 8th century, called the Justinian plague. And then the Black Plague, which occurred in 1347 and killed approximately a third of the European population. And then the pandemic that occurred starting in Hong Kong in 1894. And so on the bottom right here, I just have a map of cases between 2013 and 2018 in the world of bubonic plague. So it has not been eradicated, and cases do occasionally rise up across the globe. And so plague is transmitted through the bite of an infected flea. So the flea has bitten a rat or a mouse, and then carries plague, and which then bites a human, and then the human is infected. And then between humans, infected fleas can jump to another human, or by the louse as well, it can also be transmitted. But it can also be aerosolized and transmitted to humans through that as well. So here on the right, I show you that the infected flea bites the human, and then it migrates to the lymph node, causing bubo, and then can travel again systemically, causing septicemia. Or if it's contracted through aerosol, it will travel to the lungs and cause pneumonic plague. And so one of the main interventions, at least during the Black Death, that has been recorded is social distancing and quarantine. And so here I have a photo of something called a wine window in Italy. So during the Black Plague, in order to distance themselves but still sell wine, they created these windows in buildings where they could pass wine through the window to the customer, and then the customer would pay by placing their money into a metal tray that they would then bring back in through the window. So they never actually came into physical contact with each other. And then modern day, we treat bubonic plague with antibiotics such as ciprofloxacin, which I have here on the right. And so now moving on to smallpox, which is very deadly and very contagious. It is caused by a virus called variola virus. It can be traced back to the 3rd century BCE, I believe in Egypt, all the way up to the 20th century. And let's see. And this can be transmitted at the early rash stage through a cough, a sneeze, or through surfaces contaminated with fluid from sores. And this is something that is spread by humans only. And so even up until 1945, you can see here that there were regions endemic with smallpox. So the United States, South America, Africa, Asia. And so smallpox, again, was very deadly. It had a 30 to 40% mortality rate. But one of the earlier interventions that was introduced was something called variolation, which is basically the technique where you take scabs, dried scab pieces from someone who had smallpox, and you introduce it to a healthy person so that they would gain some sort of resistance to the to the virus. And at that time, they had no idea that it was a virus. They just knew that if they took some of this dried scab and gave it to a healthy person, that they would either not develop smallpox or develop it, a less serious version of the disease. But the fatality rate for this was still great because it wasn't very regulated. If you took something too soon and gave it to a person, they would eventually develop the disease. And then, that defeated the purpose of variolation. And so this technique was introduced into Europe from the Middle East in the early 18th century. And Lady Mary Wortley Montagu, who was wife of the British ambassador to Turkey, insisted that her children went under variolation. And then in 1796, Edward Jenner, a scientist, made the observation that milkmaids who had come into contact and developed cowpox did not develop smallpox, or if they did, it was not as serious as the smallpox that someone who hadn't come into cows developed. And so he developed basically the first vaccine, and vaccine comes from the Latin word vacca, which means cow, coming from the cowpox. And currently, we now use vaccinia virus, not cowpox, to inoculate against smallpox. And that is actually more closely related to buffalo pox. It's actually nowhere really related to smallpox, but it still confers the same type of immunity. And so the last known death was a researcher named Janet Parker in 1978. There was a naturally caused case. A person died in Somalia the year before. He had actually contracted it from an aerosol of a desiccated contaminated material from a previous pandemic. And the researcher contracted it through a lab that was searching. So almost 2 centuries after Jenner published his hope that vaccination could annihilate smallpox, in 1980, the World Health Assembly officially declared the world free of this disease. And this was through a concerted effort of nations to vaccinate everyone. So it's going to take the globe to fight diseases like this. So now I'm going to discuss cholera, which we've heard quite a bit about already this morning. It was a very interesting lecture. So as was mentioned, cholera is caused by a bacteria called Vibrio cholera. And as was mentioned, there have been many pandemics or waves of this pandemic, starting in 1817, all the way through 1961 to present day. This is caused through the transmission of contaminated water through the fecal-oral route. And if treated quickly, the mortality rate is actually less than 1%. But if left untreated, the mortality rate is 50 to 60%, so very deadly. It had originated in 1817, as I understand, in India, and then followed trade routes. But the latest pandemic actually began in Indonesia. And so on the right there, I have a photo of the bacterium. And then also, this is a historical photo from Calcutta of a patient being treated through rehydration for cholera. And so initially, the thought was that cholera was fed through miasma or bad air. And this kind of had to do with the poor sanitation. And they just kind of also had this idea that you kind of had negative energy, or if you were a bad person, that this could also somehow spread disease. But in 1854, the English physician, John Snow, who is now known as the father of epidemiology, published that he believed cholera to be sourced from water, contaminated water. And the way he did this is, I have a photo on the right here of a map of Soho, London. So he lived in Soho, and there was a small outbreak near where he lived. And he started to map out the different water pumps. So 13 different wells in the Soho district. And I don't know if you can see, there's like a little red dot there and there, here and here. And these are all water pumps. But there's one right here at the center of where the outbreak occurred. And so he had looked at water under the microscope from the different wells, and he noticed white flocculent particles. And so he believed that these were the particles that caused disease. At the same time, in 1854, in Florence, Italy, an anatomy professor, Filippo Pacini, used a microscope to look at the stool and mucosa from people who died of cholera. And he noticed small bacilli, or rod-shaped bacteria, with a comma shape that he called Vibrios, which is where the name Vibrio cholera comes from. And he also suggested that this was the source of infection for cholera. He also went further to recommend that a sodium chloride diluted water treatment could be used to treat cholera patients. And in 1883, Robert Koch, who discovered anthrax and tuberculosis and is the father of Koch's postulates of disease, he also was the first to culture microorganisms, also saw the same thing. He actually traveled to Calcutta in 1883, and I've just spelled it this way because that's how it's been written in the literature. But he also noticed these organisms in water, and he introduced filtered water pipes as an intervention for cholera. And even after all this, people still thought that it was transmitted through the air. So it took a long time before they actually, we understood that it was transmitted through contaminated water. And so it's still a very big problem today. Cholera causes 2.9 million cases per year, resulting in 95,000 deaths. But a vaccine or vaccines have been developed for use in cholera endemic populations and for travelers. And then in addition, hygiene and sanitation play a very important role in controlling cholera. And so if you look at the graph to the right, you can see that at point A, which is a person that is unvaccinated and has not used any type of improved water quality or hygiene, there's a very great probability of becoming sick when you come into contact with a certain number of Vibrio organisms. But if you are vaccinated, have improved water quality, hygiene, and sanitation, that probability of becoming sick becomes very low. So interventions do work, and they can have a great impact in controlling disease. And so now I'm going to talk about Spanish flu, which you can see here is contagious and can be quite deadly. So Spanish flu is caused by an Orthomyxoviridae family of viruses. Influenza A, H1N1, is the virus that caused Spanish flu. And so there are three families of influenza, A, B, and C. A being the ones that cause things like pandemics. B also cause disease, and then C, which are ones that really don't cause disease or, a very mild disease. And so typically influenzas are found in wild waterfowl and shorebirds, but this particular flu came from a pig. And so what also makes each influenza kind of unique and actually very difficult to target with vaccines are these surface proteins called hemagglutinin and neuraminidase, which can vary a great deal, and mutations occur very frequently that change these proteins in such a way that it's difficult to keep developing new vaccines to target them. And so during World War I is when this pandemic occurred. The exact source of it is not known, but we do know is that troops traveling across borders and across oceans help transmit this disease across the globe. And transmission is through direct contact with contaminated aerosols or droplets. And so the impact of Spanish flu was very great. It killed 40 million people and more than 600,000 in the US alone. It killed young people who were normally expected to be the least affected, which was very scary. And then here I actually was able to find this historical piece of data of the death rate in Bombay, Madras, and Calcutta between June and December 1918. So you can see here Bombay had the greatest death rate versus Madras and Calcutta. And so again, here is, I was also able to find this piece of data that shows the standardized peak excess mortality in the different regions of India, the average time to mortality, as well as the duration and midpoint of the disease during this pandemic. So during the time of the Spanish flu, there was a great debate over interventions. So there was isolation, quarantine, good personal hygiene, use of disinfectants, and limitations of public gatherings. And so I have here on the right example of 2 different US cities that took different approaches to dealing with the Spanish flu. On the left is St. Louis, Missouri, which after their very first case, immediately or very quickly thereafter, closed schools, banned public gatherings, and used some other of these other interventions listed to the left to help control the spread of the disease. And as you can see, the deaths per 100,000 in the population remained relatively low. At some point between November 3rd and December 1st, they thought maybe they could open things up again, and the death rate increased, and they immediately implemented those measures again, bringing the death rate down. In contrast, you can see that Pittsburgh, Pennsylvania, after their first case, took their time and didn't really implement any interventions, and the death rate was very high per 100,000. And so even though they implemented some of these things later on, it was a little too late by that point. But they were eventually able to get some of the deaths down. So both timing and type of intervention matter in combating disease. And this is very true for, I think, the Spanish flu, as is evident by the differences between St. Louis, Missouri, and Pittsburgh. And so again, the debate over interventions were very hotly debated during this time. The debate over masks existed. There was even an anti-mask league here in the United States. The state of California implemented a fine of $5 to $10 or up to 10 days in jail for not wearing a mask. But eventually the Spanish flu died out, either because people died or because the people who did get it survived and developed immunity. And so really that was how the Spanish flu ended. And so again, like I mentioned earlier, vaccines are very difficult to develop against influenza, mainly because between transmission between animals and humans, a virus, let's say from a bird, can co-infect a cell in a pig with a swine influenza, and their genetic material can recombine in a way that develops a new type of surface protein that can infect a human and can be difficult to target. And so scientists currently develop flu vaccines every year using their own type of algorithms and through previous knowledge to kind of predict what kind of surface proteins they can target for the next flu season. So again, new avian genome segments were imported into the backbone of the 1918 descended H1N1 virus and can cause another wave of influenza. And so now I'm going to discuss modern SARS pandemics. So here we have SARS, MERS, and then SARS-CoV-2, which is the current pandemic that we are experiencing, in context to the other diseases that we've discussed. And so MERS was not very contagious, but very deadly. SARS, again, was contagious and quite deadly. And we're still trying to figure out exactly where SARS-CoV-2 fits in this scheme. So this is kind of the lower estimate versus the higher estimate, which is very close to Spanish flu. So if you think Spanish flu was serious, I would certainly take SARS-CoV-2 as well. So the emergence of coronavirus epidemics, this is very interesting because coronaviruses, even when I was an undergrad, I had learned that coronavirus was basically just another cause of a common cold along with rhinovirus. It was first isolated and identified in the 1960s. And then in 2003, we had the SARS outbreak due to the SARS coronavirus. And this was the first well-documented human coronavirus caused pandemic. Each person could give rise to 2 more cases. It had a 10 to 20% fatality rate, infecting over 8,000, and 20 to 30% of those people required intensive care. And so most human coronaviruses originated from bats, where they are not pathogenic. And so there are seven known types of coronaviruses, which are listed here. 5 of them come from bats, and these other 2 come from, I can't remember exactly if it was rats, but they also infect cats and other types of mammals as well. And so something that is of interest with zoonosis is the fact that these viruses start in an animal, can be transmitted to other animals, and as they co-infect different animals, they can change in such a way that they become infectious to humans. And so 80% of the different animals in the markets in the Guangzhou have markets in Guangzhou have anti-SARS coronavirus antibodies. So this should show that animals in close proximity to each other and humans pose a great risk to developing a infectious type of coronavirus. And so again, to highlight this, why this is important is that you can have introduction from a reservoir, so here on the right, that can be transmitted into a human population. And maybe genetically it hasn't been, it's not in such a way that it can cause some sort of disease and eventually just dies out in this population. It can die out early, it can die out late. But at some point, it can evolve and become infectious. And so maybe for this one, it wasn't that infectious and quickly died off. But the more chances you have this, the more chances you have an opportunity for it to evolve into a strain that becomes infectious between humans. And this is the emergence of disease. So right here, this is what we need to worry about. And so the more chances we have intermingling of these reservoirs with humans and each other in close proximity can cause an issue where they evolve. And so again, just to kind of talk about viral infection of coronaviruses, SARS was the first identified that it binds to the ACE2 receptors of human cells. And so these outer proteins of the virus bind to these receptors, and that's how it is able to fuse with the plasma membrane of the cell and then transmit their genetic material to create more virus. And so as I recall, the most recent SARS, so SARS-CoV-2, actually has a greater affinity for these ACE2 receptors than the SARS coronavirus that caused the pandemic in 2003. And so again, here we have SARS, and here we have SARS coronavirus 2, again, very close to Spanish flu. And so currently there are over 19 million cases of COVID-19. There have been over 730,000 deaths. And we believe that it came from a bat that transmitted coronavirus to another intermediary reservoir that then was transmitted to a human through a market in Wuhan, China. And so the bat coronavirus shares 96% genetic homology or similarity with the SARS coronavirus 2 that is causing COVID-19. There has been some speculation because the pangolin beta coronavirus also has a striking similarity to coronavirus, and that may have been another intermediary that allowed for it to become infectious. And so the interventions currently that we're using are using masks, social distancing, hygienic practices, and then testing and contact tracing. Because currently we don't really understand 100% how transmission occurs. And so it's best to kind of use all of these tools that we have to prevent the spread of the disease. And so here I have a photo of the main attraction here in Nashville, which is called Broadway. There are a bunch of bars where there's live music. People like to come and drink and hear live bands. And we actually had our own lockdown earlier this year, and things started to open back up again. with the idea that there would be social distancing and people would wear masks and that people would not order drinks from the bar. But on June 14th, as soon as we opened, people did not follow these recommendations. And you can see here this photo of a bar on June 14th where there was no social distancing, no mask wearing, and an inspector actually showed up to this bar and closed it down. They were fined and also lost their license to serve alcohol. And so things closed down again until they could kind of get legislative things in place to kind of enforce some of these interventions. And so now you can see here from this past weekend on Broadway, there's a big sign that says, "Don't share our air." Everyone is wearing masks. While there isn't as much social distancing, people are still taking some of the interventions seriously. And so this is the most recent data of COVID-19 of cases reported in the last 7 days by country and territory or area. You can see the United States still has a big problem. We have many cases in the last 7 days, as is Brazil and India. But New Zealand had reported, at least up until this morning, that they hadn't had a new case in 100 days. And today they actually reported just, I think 2 hours ago, I read that they reported their first case in 102 days. And some of the things that countries like New Zealand, Japan, South Korea, and Vietnam have taken to combat COVID-19 have been taking very strict measures such as quarantine, lockdowns, contact tracing and testing, isolation, social distancing, and using masks. And even today, when I was listening to the report about New Zealand's first case in 102 days, they've basically gone back to a phase 2 where they're implementing very strict measures to control and figure out how that case arose and how to prevent it from spreading. As compared to some place like Sweden, which took a completely different approach, which was to allow for people to get infected and keep living their lives as normal, hoping that herd immunity would kind of take over and stop the disease. But this didn't actually work. There were too many deaths. Coronavirus kind of is this kind of perfect storm of being just contagious enough while being undetected that it spreads easily, but still deadly. And so it's very difficult to control. And so even now, only 6% of the population test positive for antibodies against coronavirus. And in order for there to be successful herd immunity, you need over 96% of the population to have these antibodies. And so other countries also debated whether they should take this approach and quickly realized that based on how the disease spread, that there would be too many deaths and the healthcare systems would be overwhelmed. And in addition to that, we don't really understand if you can, catch coronavirus again. How long does that immunity even last if you have immunity to coronavirus? So these are kind of some of the debates about interventions and what we were kind of learning in real time about COVID-19. Okay, so now as far as other interventions, there are currently over 135 vaccines in preclinical trials. There are 8 currently in phase 3, including one that is approved for limited use, and this is from CanSinoBio in China. And so there is a race right now to find a vaccine that will stop the pandemic. And so there are really 3 types of vaccines currently developed. I'm going to call them first, second, and third generation vaccines. The first being something like what we use for smallpox, which is a weakened virus. And so the Institute of Medical Biology at the Chinese Academy of Medical Science is trying to develop a vaccine against a weakened coronavirus. Then there are second generation vaccines, which target a component of the virus. So in the case of coronavirus, it's targeting this surface protein, which I have circled in red here. And so they basically just produce that part of the virus. and are using it as a vaccine to induce or elicit an immune response. And this is being made by Norvax in collaboration with the Serum Institute of India, which is the largest producer of vaccines in the world. And then the last type of vaccine in development is a third generation vaccine, which there has never been an approved vaccine of this type. So this actually targets just a segment of the genetic material in the virus. And so this is being developed by Moderna in conjunction with, or in collaboration with, the University of North Carolina, Chapel Hill, my home Vanderbilt University Medical Center, and the University of Texas at Austin. And so again, there is a big race right now which vaccine will be approved. But right now it seems that it is very likely it might be the Norvax or Moderna type of vaccine. And so some of the remaining questions I kind of want to pose to you is, can we live with other pandemics like this? Are other pandemics like SARS-CoV-2 preventable? And will this change future behavior? For example, will there now be routine testing at airports? Will there be better funding for research into influenza and coronaviruses? Will there be an end to open-air animal markets? And will governments take a stronger stance and have pandemic task force to help kind of combat these things on the front end? And just as a comment to the better funding, when SARS pandemic in 2003 occurred, there was a group in Baylor University in Texas that had been developing a coronavirus vaccine. And as the SARS pandemic died out, so did the funding. And the question remains now is, if they had still had funding, would we be in clinical trials further along for the current coronavirus if we had continued to fund them? So I appreciate your time and your attention. And again, it's my honor to give this presentation here to you today.
Thank you, Dr. Campos, for such an in-depth analysis of not only the coronavirus, but all pandemics in general. It was really insightful. Thank you for your talk. I would now call upon Professor Suparna Ganguly to please conduct the interactive session for Dr. Campos.
Thank you, Piali. Actually, questions are pouring in for Dr. Lillian, but because of shortage of time, we won't be able to take all of them, but I'll try and club the similar questions together, at least to cover the maximum part of it. So to start with, we have a question from Oyon Thakur. Okay, Dr. Campos, should I present the questions one by one, or I'll give you the questions first and then you'll like to respond to it?
Oh, one by one would be great.
One by one. Oh, thank you. So it's from Oyon Thakur. He's asking, to what extent a pandemic can destroy the social capital and social bonding?
That's a very interesting question. I take the approach more from the scientific standpoint, not really a sociologist. I think it is a very interesting question, though, but I would probably pose that to a sociologist, because I do see, even just as a person, that having to isolate yourself really changes the dynamics and of how people are interacting even now. So as we're having this webinar, this has been a big change to how we would have seminars before coronavirus.
Right. The next one is from Dr. Chandrani Chatterjee. She wants to know how early it is possible to get remedy from this pandemic caused by COVID-19 virus.
So clinical trials take quite a long time to make sure that vaccines are safe and effective. As I understand it, the very earliest that we could have a vaccine approved will probably be probably late spring, best case scenario next year.
Mollika Basu asks how far vaccine will be effective in combating this latest coronavirus. What do the Oxford scientists believe on this matter?
That's still up for debate. As these vaccines are being trialed, that's kind of how we're going to understand whether or not these vaccines will be effective. So, and we're hoping that they will be effective, and typically vaccines are actually elicit a stronger immune response, or have a longer lasting immune response than actually getting the infection itself. So vaccines are actually a much better way to combat the virus than, let's say, allowing for everyone to catch it and for there to be herd immunity. So vaccines tend to give a longer lasting kind of memory to our immune system.
Right. So the next one is from Mr. Ghanasham Giri, who writes that we already have the knowledge of cholera, smallpox, and Spanish flu. How can we implement our existing knowledge and ideas to fight coronavirus?
Well, my biggest hope was that people will start to believe scientists as we study this and we gain information. I hope that what we learn is that we should trust where the information takes us, to follow evidence and not anecdotal evidence, or just ideas that haven't been supported by scientific evidence. And hopefully people will implement some of these things in their daily life. I think basic hygienic practices, I think this has highlighted that maybe people were not as hygienic as we hoped. And so hopefully people will carry these hygienic practices on to prevent other diseases, not just coronavirus.
So the next one is from Partha Shorkar. He's asking, Spanish flu of 1918 attacked mainly the youth, and this coronavirus is posing the threat mainly to the older generation primarily. So is it true that a virus has polarized targets?
So typically, I mean, it has more to do with the immune response. So for people, that are aging, typically their immune system is not as strong as that of a young person. I think that was what was so scary about the Spanish flu, is that it didn't matter. It targeted young and old alike. But typically, if you have a weakened immune system, or if you have pre-existing conditions, this already makes you susceptible in general to any type of infection.
Right. The next one is from Shubham Roy. He wants rather a specific definition of vaccine. Like, what is the definition of vaccine and what it actually do to us?
So the vaccine is basically you are inoculated with either a weakened virus, a particle of a virus, or, as will hopefully maybe work with the Moderna vaccine, a piece of the genetic material. And basically the idea is that you introduce these components into your body and elicit an immune response, so that your immune cells recognize it. They recognize this does not belong. And so once it learns what does that look like, it can target it. And if you encounter that component or that virus again, your body will remember and then attack it, preventing disease.
Last one, that's from one of our colleagues from our college only. So it is clear that there are many misconceptions as well as myths regarding pandemics or epidemics. So in this context, what is your take on this? Like, how can we combat these misconceptions to eradicate them?
Yeah, so I think, again, following science, listening to scientists, our whole purpose is to discover what is fact through evidence and observation. And so, it's not perfect. It is a self-correcting system, though. So as we learn more information, we can self-correct and have a better idea of what is going on. So I would say it's better to be safe than sorry. And so in the early days, I know that there was a lot of pushback about, lockdowns and quarantines and even social distancing. And, it just seems that, for example, even for masks, it's better to be safe than sorry. So even if a mask is not 100% effective in preventing you from getting coronavirus, even if it's only 50% effective, that's better than zero. And there's a great misconception that masks do absolutely nothing. And scientific evidence has more recently shown that it does something. It may not be 100%, but it's much better than zero.
Okay, thank you so much, Dr. Lilian Campos, and that was all for this session. And I hand this over to Professor P. Said for the rest of the sessions.
Thank you very much.
Thank you again, Dr. Lilian Campos, for your responses. And thank you, Professor Ganguly, for conducting this session. This brings us to the last leg of our webinar today, which is the valedictory session, which is to be delivered by Professor Dr. Mohammad Anwarul Islam. I take the pleasure to introduce him to all of you. Professor Dr. Mohammad Anwarul Islam did his PhD in history titled Education in Colonial Bengal, a study in selected districts in Eastern Bengal, 1854 to 1947, from North Bengal University in India. He has been serving from the year 2016 to up till now as Pro-Vice Chancellor of Pabna University of Science and Technology in Bangladesh. He is a member of the Selection Committee of Lecturer and Assistant Professor of Archaeology, Department of Jahangir Nagar University, Savar in Dhaka. He has also been a member of the Selection Committee of Lecturer and Assistant Professor of Archaeology Department of Comilla University in Comilla, Bangladesh. He served as the administrator of the Chittagong University and is a syndicate member of Cox's Bazar International University. Further, he is the director, Institute of Modern Languages, Pabna University of Science and Technology in Pabna. Sir, I welcome you to our webinar and I would request you to kindly deliver the valedictory session for today.
Thanks. Dear Honorable Principal of Prafulla Chandra College, panel speaker Dr. Sujata Mukherjee, Department of History, Ravindra Bharati University, and Dr. Lilian Campos, Department of Biochemistry, Vanderbilt University, USA. Ladies and gentlemen, distinguished guests, listener, Assalamu alaikum and very good afternoon. It is my great pleasure and at the same time I am very much thankful to the authority of Prafulla Chandra College, Kolkata, especially Professor Kekadi giving me this honor and opportunity. For her support, I joined this international webinar. The COVID-19 pandemic, also known as the coronavirus pandemic, is an ongoing global pandemic of coronavirus disease 2019 or COVID-19. The outbreak was first identified in December 2019 in Wuhan, China. The World Health Organization declared the outbreak a public health emergency of international concern on 30 January 2020 and a pandemic on 11th March. As of 9th August 2020, more than 20 million cases of COVID-19 have been reported in more than 188 countries and territories, resulting in more than 8 million deaths. More than 12 million people have recovered. At the same time, more than 4 billion people, or half of the world's population, have now been asked or ordered to stay at home by their governments to prevent the spread of the deadly COVID-19 virus. Like other pandemics, COVID-19 pandemic, now it is a major de-establishing threat to the global economy. This pandemic has caused global social and economic disruption, including the largest global recessions since the Great Depression and global famines affecting 265 million people. it has led to the postponement or cancellation of sporting, religious, political, and cultural events. Widespread supply shortage intensified by panic buying. Schools, universities, and colleges have been closed either on a nationwide or local basis in 161 countries, affecting approximately 98% of the world's student population. Misinformation about the virus has circulated through social media and mass media. The United Nations has coordinated the global response to the coronavirus pandemic, led by its Secretary General. The response can be divided into formal resolutions at the General Assembly and at the Security Council, and operations via its specialized agencies, chiefly the World Health Organization, in the initial stages, but involving more humanitarian oriented agencies like UNICEF, ILO or International Labour Organization, and the United Nations High Commissioner for Human Rights. As the humanitarian impact became clearer, and then economic organizations like the United Nations Conference on Trade and Development, the International Monetary Fund, IMF, and the World Bank, as the socio-economic implications degenerated. Many studies explored suggesting the COVID-19 pandemic will likely go down in history as the costliest disaster ever in human history. The business sector has been impacted globally with reductions in store hours or temporary closures. Visits to retailers in whole world declined by 30 to 40%, especially North America and Middle East retailers saw a 50 to 60% drop. This also resulted in a 33 to 43% drop in foot traffic to shopping centers in March compared to February. Shopping mall operators around the world imposed additional measures such as increased sanitation, installation of thermal scanners to check the temperature of shoppers, and cancellation of events. Tourism is one of the worst affected sectors due to travel bans, closing of public places, including travel attractions, and advice of governments against travel. Numerous airlines have cancelled flights due to lower demand, and regional airline collapsed. The cruise line industry was hard hit, and several train stations and ferry ports have also been closed. International mail between some countries stopped or was delayed due to reduced transportation between them or suspension of domestic service. 100 millions of jobs could be lost globally. More than 40 million people lost their jobs. According to a United Nations Economic Commission for Latin America estimate, the pandemic induced recessions could leave 14 to 22 million more people in extreme poverty in Latin America than would have been in that situation without the pandemic. The outbreak has been blamed for several instances of supply shortage stemming from globally increased uses of equipment to fight outbreaks, panic buying, which in several places lead to shelves being cleared of grocery essentials such as food, toilet paper, and bottled water, and disruption to factory and logistics operations. The spread of panic buying has been found to stem from perceived threat, perceived scarcity, fear of the unknown, copying behavior, and social psychological factors. The technology industry in particular has warned of delays of shipments of electronic goods, According to the World Health Organization Director General, demand for personal protection equipment has risen a hundredfold, leading to prices up to 20 times the normal price and also delays in the supply of medical items of 4 to 6 months. It has also caused a shortage of personal protective equipment worldwide, with the World Health Organization warning that this will endanger health workers. The impact of the coronavirus outbreak was worldwide. The virus created a shortage of raw materials used in the manufacturing. The pandemic has disturbed global food supplies and threatens to trigger a new food crisis. According to the World Food Programme, quote, we could be facing multiple famines of biblical proportions within a short few months, unquote. Senior officials at the United Nations estimate in April 2020 that an additional 130 million people could starve for a total of 265 million by the end of 2020. The pandemic, alongside lockdowns and travel restriction, has prevented movement of aid and greatly impacted food production. As a result, several famines are forecast, which the United Nations called a crisis of biblical proportions or hunger pandemic. It is estimated that without intervention of 30 million people may die of hunger, with Oxfam reporting that 12,000 people per day could die from COVID-19 linked hunger, unquote, by the end of 2020. This pandemic, in conjunction with the 2019 to 20 locust infestations and several ongoing armed conflicts, is predicted to form the worst series of famine since the Great Chinese Famine, affecting between 10 and 20% of the global population in some way. 55 countries are reported to be at risk, with 3 dozen submitting to crisis level famines or above in the worst case scenario. 265 million people are forecast to be in famine conditions, an increase of 125 million due to the coronavirus pandemic. Now, I discussed social impacts of the COVID-19 pandemic on the arts and cultural heritage, like on education, on cinema, on religion, on sports, on television, on video games, on performing arts, and on music. Uh, Now we are seeing the effects of coronavirus on our everyday life. Even now, coronavirus means the end of the social kiss or handshake. Will this tilt cultures away from past social greetings? That some Ayan Thakur, he already he have comments, social capital and social বন্ডিং নষ্ট করার ক্ষেত্রে কতটা প্রভাব ফেলতে পারে এই করোনা মহামারী ব্যাধি। Already, I think already he has been answered. In the wake of COVID-19, established social etiquettes around the world have dramatically changed, and this change is bound to be a permanent one. Maintaining 6 feet of distance at all times, wearing a mask in public, and standing in designed areas in public places have all become the new normal. This sudden and extended social change has struck a string of permanence in a frightened population, and it is would mean the end to how we once interacted. The pandemic has affected educational systems worldwide, leading to the near total closure of schools, universities, and colleges. Already I have mentioned, most governments around the world have temporarily closed educational institutions in an attempt to contain the spread of COVID-19. As of 27 July 2020, approximately 1,725 billion learners are currently affected due to school closures in response to the pandemic. According to UNICEF monitoring, 106 countries are currently implementing nationwide closures and 55 are implementing local closures, impacting about 98.6% of the world's student population. On 23rd March 2020, Cambridge International Examination released a statement announcing the cancellation of Cambridge IGCSE, Cambridge O-Level, Cambridge International and A-Level, Cambridge AICE Diploma and Cambridge Pre-University examinations for the May-June 2020 series across all countries. Internationally, many exams have also been cancelled. In addition, advanced placement exams, SAT administrations, and ACT administrations have been moved online and cancelled. School closures impact not only students, teachers, and families, but have far-reaching economic and social consequences. School closures in response to the pandemic have shed light in various social and economic issues, including student debate, digital learning, food insecurity and homelessness, as well as access to childcare, healthcare, housing, internet, and disability services. The impact was more severe for disadvantaged children and their families, causing interrupted learning, compromised nutrition, childcare problems, and consequent economic cost to families who could not work. In response to school closures, UNESCO recommended the use of distance learning programs and open educational applications and platforms that schools and teachers can use to reach learners remotely and limit the disruption of education. The performing arts and cultural heritage sectors have been profoundly affected by the pandemic, impacting organizations, operations, as well as individuals, both employed and independent globally. Arts and culture sectors organization attempted to uphold their mission to provide access to cultural heritage to the community, maintain the safety of their employees and the public, and support artists where possible. By March 2020, across the world and to verifying degrees, museums, libraries, performance venues, and other cultural institutions had been indefinitely closed with their exhibitions, events, and performances cancelled or postponed. In response, there were intensive efforts to provide alternative services through digital platforms. Religious bodies also cancelled in-person services and limited public gatherings in churches, mosques, and temples. Saudi Arabia banned the entry of foreign pilgrims to holy sites in Mecca and Medina. The pandemic has caused the most significant disruption to the worldwide sporting calendar since the Second World War. Most major sporting events have been cancelled or postponed, including the 2019-20 UEFA Champions League, 2019 Premier League, UEFA Euro 2020, 2019 NBA session, and 2019 NH League session. The outbreak disturbed plans for the 2020 Summer Olympic in Tokyo, Japan. which were originally scheduled to start at 24 July 2020 and were postponed by the International Olympic Committee to 23 July 2021. The entertainment industry has also been affected, with many music groups suspending or canceling concert tours. Some artists have explored ways to continue to produce and share work over the internet as an alternative to traditional live performance, such as live streaming concerts or creating web-based festivals for artists to perform, distribute, and publicize their work. Online numerous COVID-19 themed internet memes have spread as many turn to humor and distraction amid the uncertainty. The pandemic has affected the political systems of multiple countries, causing suspensions of legislative activities, isolations, or deaths of multiple politicians, and rescheduling of elections due to fears of spreading the virus. Although they have broad support among epidemiologists, social distancing measures have been politically controversial in many countries. Intellectual opposition to social distancing has come primarily from writers of other fields, although there are few heterodox epidemiologists. The measures taken to combat the pandemic are part of an unusually large expansion of government power. Advocates of a small government worry that the state will be reluctant to give up that power once the crisis is over, as has often been the case historically. On 23rd March 2020, United Nations Secretary General is issued an appeal for a global ceasefire in response to the pandemic. 172 United Nations member states and observers signed a non-binding statement in support of the appeal in June, and the United Nations Security Council passed a resolution supporting it in July. The pandemic has had many impacts on global health beyond those caused by the COVID-19 disease itself. It has led to a reduction in hospital visits for other reasons. There is also concern that people with strokes and appendicitis are not seeking timely treatment. Shortage of medical supplies have impacted people with various conditions. In several countries, there has been a marked reduction of spread of sexually transmitted infections, including HIV, AIDS, attributable to COVID-19 quarantines, social distancing measures, and recommendations to not engage in casual sex. Similarly, in some places, rates of transmission of influenza and other respiratory viruses significantly decreased during the pandemic. The pandemic has also negatively impacted mental health globally, including increased loneliness resulting from social distancing. Since the start of the outbreak, uh, racism have been documented around the world toward people of Chinese and East Asian descent. Reports from February documented racist sentiments expressed in groups worldwide about Chinese people deserving the virus. Chinese people and other Asians in the United Kingdoms and United States have reported increasing levels of racist abuse and assaults. United States President Donald Trump has been criticized for referring to the coronavirus as the Chinese virus unquote and quote Kung flu unquote, which critics say is racist and anti-Chinese. Following the progression of the outbreak to new hotspot countries, people from Italy, the first country in Europe to experience a serious outbreak of COVID-19, were also subjected to suspicion and xenophobia, as were people from hotspots in other countries. Paris has seen riots break out over police treatment of ethnic minorities during the coronavirus lockdown. Racism and xenophobia towards South Asians and Southeast Asians increased in the Arab states of the Persian Gulf. South Korea's LGBTQ community was blamed by some for the spread of COVID-19 in Seoul. In China, xenophobia and racism against non-Chinese residents has been inflamed by the pandemic. A comic posted on Weibo described foreigners as quote foreign garbage unquote targeted for quote disposal unquote. Some black people were evicted from their homes by police and told to leave China within 24 hours due to disinformation that they and other foreigners were spreading the virus. Other harassment, discrimination, and evictions of Africans in China were alleged. This racism and xenophobia was criticized by foreign governments and diplomatic corps and the Chinese ambassador to Zimbabwe. A McDonald's branch in Guangzhou bearing blacks sparked anger in China and overseas, and McDonald's closed the location. Some newspaper agencies removed their online paywalls for some or all of their coronavirus related articles and posts, while scientific publishers made scientific papers related to the outbreak available with open access. Some scientists chose to share their results quickly on preprint servers such as BioRxiv. The pandemic has resulted in misinformation and conspiracy theories about the scale of the pandemic and the origin, prevention, diagnosis, and treatment of the disease. False information, including intentional disinformation, has been spread through social media, text messaging, and mass media, including the tablet media, conservative media, and state media of countries such as China, Russia, Iran, and Turkmenistan. It has also been reportedly spread by covert operations backed by states such as Saudi Arabia, Russia, and China to generate panic and show distrust in other countries. In some countries such as India, Bangladesh, and Ethiopia, journalists have been arrested for allegedly spreading fake news about the pandemic. Misinformation has been propagated by celebrities, politicians, and other prominent public figures. Commercial scams have claimed to offer at-home tests, supposed preventives, and miracles cures. Several religious groups have claimed their faith will protect from the virus. Some people have claimed the virus is a bioweapon, accidentally or purposefully leaked from a laboratory, a population control scheme, the result of a spy operation, or the side effect of 5G upgrades to cellular network. The World Health Organization has declared an quote infodemic unquote of incorrect information about the virus, which poses risks to global health. Now a question: have epidemics shaped the modern world? Epidemics like the coronavirus outbreak are a mirror for humanity, reflecting the moral relationships that people have toward one another, the historian Frank M. Snowden says. In his new book, Epidemics and Society from the Black Death to the Present, Frank M. Snowden, a professor emeritus of history and the history of medicine at Yale, examines the ways in which disease outbreak have shaped politically crushed revolutions and entranced racial and economic discrimination. Epidemics have also altered the societies they have spread through affecting personal relationships, the work of artists and intellectuals, and the man-made and natural environments. Gigantic in scope, stretching across centuries and continents, Snowden's account seeks to explain to the ways in which social structures have allowed disease to flourish. Quote, epidemic disease are not random events that distress societies capriciously and without warning, unquote. He also wrote, quote, on the contrary, every society produced its own specific vulnerabilities. To study them it is to understand that society's structure, its standard of living, and its political priorities, unquote. As reports on the spread of COVID-19 tanked markets around the world and government engaged in varying degrees of preparation for even what's to come. During our conversation, which has been edited for length and clarity, already we have seen the politics of restricting travel during epidemics, how inhumane response to sickness have upended governments, and the ways that artists have dealt with mass death. In my conclusion, COVID-19 has affected every aspect of life around the globe, from individual relationships to institutional operations to international collaborations. As societies try to defend themselves through severe restrictions on people's movement and interactions, the disease continues to decimate families, upend governments, crash economies, and tear through the social sector. The interconnectedness and vulnerabilities of the complex systems that make the modern world run have never been more apparent, because epidemics are a category of a disease that seem to hold up the mirror to human beings as to who we really are. That is to say, they obviously have everything to do with our relationship to our mortality, to death, to our lives. They also reflect our relationships with the environment, the built environment that we create, and the natural environment that responds. They show the moral relationships that we have toward each other as people, and we are seeing that today. I have come to end my paper. So finally, again, thanks to all the speakers and organizers for this international webinar session. Now I am looking forward to Professor Piali Shet, joint convener for next proceed. Good evening, everybody.
Good evening, sir, and I'm very gratitude with extreme gratitude. I am expressing my thanks to you for delivering this valedictory session. This gives me the pleasure to announce that we have come to the end of our webinar today, and I'm glad to introduce to you Professor Dr. Angshuman Mukhopadhyay. Professor Dr. Angshuman Mukhopadhyay is the head of the department from the Department of English, Prafulla Chandra College, to please kindly deliver the vote of thanks today.
Good evening, everyone. Although it's almost like it's customary to deliver a vote of thanks, I'm being entrusted with the responsibility of doing this, which is more like bidding a ritual goodbye after thanking the people associated with our program and its success. For 2 days now, that is yesterday and today, we have been listening to some stalwarts, some extremely interesting presentations, deliberations, so to say, from the likes of Professor Dr. Deepak Kumar, Professor Dr. Mohua Sarkar, Professor Dr. Sujata Mukherjee, Professor Dr. Anwarul Islam, Dr. Rajarshi Chakraborty, and Dr. Lillian Campus. Their deliberations tapped a wide range and variety of subjects connected with the pandemic and its historicity, to be precise, its contexts, its effects, socio-cultural, economic effects, perceptions regarding the urban and rural divide when it comes to a pandemic, sanitation system, and so on, and even the genealogy of the pathogen causing this pandemic, so to say. And on behalf of the college, I thank them all. I thank all the speakers from the bottom of my heart. And I thank our principal, Dr. Ratnakar Pani, for constantly enthusing us, and he has always been there encouraging us to proceed with all these webinars that we have been able to conduct so far. And I thank Professor Dr. Keka Dottorai, the head of the Department of History, for conceptualizing this program. Professor Piali Shet for ably and wonderfully supporting Professor Keka Dottorai. And then the coordinator of the IQAC of the college, that is Professor Dr. Shonali Roy, who has been with us through thick and thin, and she's always there trying to improve the academic profile of the college, so to say. And then, obviously, I would like to thank Dr. Abul Salam, our technical expert, who has been unfailingly supporting us through almost all the webinars that we have been conducting so far. And finally, I would like to thank the audience who has been patiently listening to all the deliberations for 2 days now, because without the audience, such webinars obviously wouldn't mean anything, right? So thank you all. I hope you have been able to enjoy all the speeches as I have been able to do that, in spite of certain technical glitches, so to say. But then those things are part and parcel of this new normal that we are getting used to. Now, I would like to invite Professor Keka Dottorai once again to say some final words to clinch it almost ceremoniously, so to say. Thank you. Kekadi. Kekadi, kindly unmute yourself.
Can you hear me?
Yes, Kekadi.
Can you hear me?
Yes, thank you. Yes.
My heartiest gratitude to all the distinguished speakers who've spoken yesterday and today, and to all the participants and the organizers of the college who have made this program a grand success. And before we leave the screen, please remember the words of Kavi Guru Rabindranath, who wrote The Crisis of Civilization, Shonkachara Viholata, Nijeder Opinion. May we have the song? May we have the song? Dr. Salam?
Dr. Salam, we are
Excuse me.
not able to, Piali, would you go for it? Or we are not, actually the audio is not working. I guess we can't really hear anything.
Yes.
So could you please see that?
Sorry for the interruption. Okay, thank you.
পরিচয় নিজের দিও কঠিন পরিচয় কর কাজে নিজের দিও কঠিন পরিচয় সংকটের কল্পনাকে ভুলো না প্রিয়মান সংকটের প্রিয়মানতা নিজের অপমান সংকটের কল্পনাকে ভুলো না প্রিয়মান মুক্ত করো ভয় আপনা মাঝে শক্তি ধরো নিজের করো জয় মুক্ত করো ভয় আপনা মাঝে শক্তি ধরো নিজের করো জয় সংকটের প্রিয়মানতা নিজের অপমান সংকটের কল্পনাকে ভুলো না প্রিয়মান মুক্ত করো ভয় নিজের পরে করিতে পারে নারীক সংশয় মুক্ত করো ভয় নিজের পরে করিতে পারে নারীক সংশয় সংকটের প্রিয়মানতা নিজের অপমান সংকটের কল্পনাকে ভুলো না প্রিয়মান মুক্ত করো ভয় দুরূহ কাজে নিজের দিও কঠিন পরিচয় মুক্ত করো ভয় দুরূহ কাজে নিজের দিও কঠিন পরিচয় সংকটের বিহ্বলতা নিজের অপমান সংকটের কল্পনাকে ভুলো না প্রিয়মান
Stay safe and stay home, and good night, everybody.